through it. That was like 3 hours.
All right, let's get started. Everybody ready? All right, Katie's here, so we can get started.
Come on, let's go. Come on, Katie.
We've been waiting for you. Yeah, we're waiting for you for 10 minutes. Okay, today's discussion is odontoid fractures, and just like always, any questions, just interrupt me. So who knows what odontoid means? Grant knows everything. Grant? What's the arrow point to?
I'll be honest, as a guess, based on the picture, I would say it's a
Tooth. Yeah, dentist, like dentist, odondi means tooth in Greek. So it's also called dens. Maybe when 100 years ago, when Paul was in medical school, processus epistrophysis, is that what they used to say, Paul, back in the old days?
yes, exactly.
Okay, so this is a real case. 69-year-old man with a C2 fracture. He was admitted to one of our hospitals at MedStar for congestive heart failure, and while hospitalized, he walked to the bathroom in the middle of the night and fell, and he had a big laceration to his forehead, and he had neck pain. He called for help, and they immediately ordered a CAT scan, and he just had neck pain. And past medical history, he's a very sick man, many medical problems, COPD, congestive heart failure, anxiety, depression, cirrhosis, cognitive decline, pulmonary hypertension. He lives in a group home. So what would you do if they called you, Ocean, and you were on call?
So the first thing I would do is put him in some sort of heart collar just to stabilize everything after we got the CT scan.
Mm-hmm. Would you order a CT scan immediately?
Probably would have started with x-rays personally, but I'm thinking that worker, I guess, it's just like a trauma workup from the fall, and he's got head trauma and stuff like that.
Yeah, so he hit his head. Okay.
And then you have to just get a good neurological exam with upper lower extremities. After which I would probably give one of you guys a call.
Okay. And what do you think of the CAT scan? What do you see?
He's got kind of diffuse degenerative changes in both the bodies, lots of discite as well. It looks like there's a fracture, potentially the dens there, given the nature of our talk also, but there's a vertical line.
Yeah, it's a clear fracture.
What could potentially?
No,
It's a clear fracture.
It's a fracture.
Yeah.
Yeah. I don't know why.
So how would you describe the fracture? If you run Paul and Teller to attending.
So if I'm just looking at this cut, I mean, there's a...
Yeah, we'll look at this cut there, right?
So if we're looking...
I don't care what you do, just describe the fracture.
It's not a trick question.
Right, I mean, so this is, see, this should be C1 right here, right? So this is C2.
Yeah.
So then you have this kind of avulsive tip, fracture at the tip of the dent.
Where's the tip? Show me the avulsion.
Well, it should start here and should go up. So there's this kind of extended.
I don't think that's a tip. I think the tip.
Where's the anterior arch of C1? You pointed to the posterior arch of C1. Where's the anterior arch of C1?
He's right. Yeah.
I mean, should be. Show me.
Here.
Right. Okay. So where's the odontoid? The top of the odontoid.
You're coming up right behind it.
Okay. So what is that big clothespin looking thing that's attached to the C1 arch?
This out here?
No, attached to the C1 arch. Go down. Go.
Ocean, did you drink coffee today? Come on.
Yeah, Ocean. What is this whole thing right here?
That is the dent that's going up.
Yeah, okay, so this is the dent, right? The dent is right next to the C1 arch, right? Okay, so where is it supposed to be?
Well, it's supposed to be more anterior than it is.
Like where?
This whole piece should be right here.
Okay, so show if you, this is the odontoid, right? So show me draw where it should be.
Tracing. So it should just go up.
Yeah, he understands.
It's a clothespin, right? So this should be straight up like this. So this whole thing should be way up over here.
The interior, yeah.
Right, so how would you describe that fracture?
So then I would actually, instead of saying it's a tip, it's probably more at the waist, there's some posterior kind of subluxation of that entire piece, as well as that anterior arch of the C1 vertebrae.
Right, so it's mildly displaced and posteriorly angulated, right? But
Right.
it's, what type of fracture is this?
So then I guess it would be a type 2 fracture.
Great, type 2 fracture, right through the waist of the odontoid.
Yeah, so it's not only is it translated posteriorly, but it's angulated. The superior portion is angulated, right?
Right.
Would you think? Because it should be straight up and down. So, and it's displaced, usually if you say something's displaced, you should also quantify it. Like how much? Is it 50%, 40,
yeah.
huh? How much?
Like 50%.
50%, yeah, about 50%. Okay, very good. So you put him in a hard collar. Now, this is his X-ray the next day. So what do you think of the X-ray? So you follow people with serial X-rays, not with serial CAT scans. So you always want to get an X-ray for baseline, right? So you can follow them and see if it gets worse, displaced, et cetera. What do you think of the X-ray? Is it displaced, non-displaced? Can you tell? Maybe you can't tell.
I can't really tell.
Okay. Anybody else want to take a shot of it? What do you think, Frank? Is it displaced, non-displaced?
It looks pretty minimally displaced.
I think it looks,
Yeah,
it looks great.
What else can you use to determine whether it's in position or not? If you can't, obviously you have a hearing aid right over the area. So what else can you use to look at that, as far as alignment of the cervical spine?
You mean like a CT scan, or you mean like a
No,
different view?
Anatomical, what
From that
anatomical?
X-ray,
So the dens.
what else are you looking at?
He's getting at what else? The dens looks good. What else can you look at? What else can you
Well, if you
see?
can't see the dens, what else can you look at, can you see to try to determine whether there's alignment or not of the upper cervical spine?
You can see the dens right there. That's like,
Talking about the posterior, the C1 arch, right?
Mhm.
I mean, this should all line up.
what line's that he's pointing?
So if this is posterior to
What line is this, guys?
2, then this is
Spinal line.
probably a little more posterior line, right? I mean, Carlton?
Yeah.
Shouldn't that all be in line and in a normal patient?
Spinal laminar line looks good. How about
Right,
this?
So I'm saying, so if you can't see
How
that
about this?
because you, at least you should, the whole head, it's gonna be moving, that should all be lined up.
What's this thing at the front? It's not a trick question. See, yeah, that's anterior to this line too, right? What's that? Come on, somebody knows. Yeah, anterior C1, yeah. So that's lined up perfectly. The dens looks good, spinal lamina looks good. So the X-ray looks excellent.
Well, this could be a tricky place to evaluate on X-ray, and I agree with everything that's been said, and we are seeing we are seeing the fracture, we are seeing the displacement, but there will be times like this where you look at the X-ray and you say, gee, I don't see anything I'm supposed to be seeing, and this is just where I'm worried about. So you need to differentiate between a poorly positioned X-ray and real pathology, potentially serious pathology. So things I use to help out with the X-ray is to look at the mandible. And so the inferior ramus and the mandible, they should overlap so that this patient's head is slightly tilted. And also the back of the mandible, the patient is slightly rotated. So
Did you hear that, Frank? In the operating room, that will help you a lot.
Yeah.
Just don't ever forget what he just said.
and this can be difficult. You have a patient who is injured, who is elderly. So this can be a very hard thing. Luckily, now we have CAT scans. We really need to know we can do that. But these are ways you can figure out whether you have a good X-ray and whether if you're not seeing things, why. Because other things can happen here. Of course, you can get the skull off of the spine. You can get the cervical spine impacted with the foramen magnum. Those are situations where you say, gee, what's going on? Those are obviously very serious. And then there's normal, but you just can't see it until you get a properly positioned X-ray. The other thing I always touch on is collimation. So collimation means you bring the collimators, the shutters down to just the anatomy you want to see. That gives you less dose, but even more importantly, it gives you a better X-ray. It gives you cleaner beams.
That's another thing very important in surgery, what he just said. So he's telling us how to do fluoro in surgery. Very important. And also center the beam where you want to see. Very, very important. So all those things you should, and drop, very important.
So how old is the patient?
69. So this is, Mesfin, 69-year-old man, they called in the middle of the night, he went to go to the bathroom, fell, struck his head, lacerated his head, and he has a C2 fracture. So who can tell me why is it displaced here and why is it reduced here? Yeah. Yeah, so this is probably his typical posture. Most old people don't stand, like me, I don't stand straight. And I never lay flat ever. I have to have a pillow. So as you get older, you get arthritic. So he's slightly curved anteriorly.
And his neck is also, his jaw, his head is flexible. So if you flex, if you have a posture displacement and you bend your head forward, you're gonna reduce, right?
So luckily, the pattern of his fracture, it helps to stand. So it reduces when he stands. And the other thing is, I always use, what's another proxy for health in this guy? On this? Yeah, he's a dentulous, yeah. So it's always
Unless it's from West Virginia, then that's all, then you have.
Well, he's got one, that'd be a positive predictive value. That's actually why I was asking how old he was.
Yeah. So it's a proxy for health, yeah.
It's be a 29-year-old lady and so
Okay. So,
Very careful. Did you make the point that, of the last 25 fractures we've seen in Memorial, 24 and a half are odontoid fracture. So, it has to do with the patient population that was brought here after trauma as opposed to, if you look at that same 25 downtown. So this is the fracture we see.
and also, it's a very good point you make for everyone. It's a very, very common fracture, and it's going to get even more common as our population gets older. So in the United States, they say, some people call it like the silver wave of 2030. Basically, when I get Social Security, there's going to be a lot of people like me, and we're all going to get these odontoid fractures. So it's going to get more and more common. These elderly senior odontoid fractures. So the AP view you can't really see, but in the open mouth, what do you think there? So who can describe it? Brian Gallagher, you're looking.
So you can see in the open mouth, it's sort of, that redemonstration of your type 2 odontoid fracture. It doesn't look like there's significant like coronal deviation.
And this is what here?
This is your lateral mass of C1.
The lateral aspect of the lateral mass C1, and this is?
That's going to be the body of C2.
Yeah, so it
doesn't look like there's been any like displacement or separation of the lateral masses.
But don't you think this point here should line up with this point here?
Yeah, it looks like the whole thing looks like it's laterally
Subluxating to the left, yeah.
Okay.
Yeah, and this point here should line up with this point here. Don't you think?
Yeah.
So subluxated some. It's not a big deal, but you should know what these things look like.
Right, I agree with all those findings. The patient is again slightly rotated, all right, so that's going to produce part of that. You can see the midline is a little left, the midline anterior mandible is a little left, and the midline posterior spine. And again, this is not something you have looked a lot at, the plain film of the odontoid. This can be, again, a very tough exam to get. Open mouth odontoid, right? Not everybody can open their mouth. There are other ways to get that, but again, we default to CT rather than put people into hyperextension and get it that way. So what do you think this line is here, this curved line here? I'll give a shot at that.
Yeah,
Pardon? No, but this is the palate up here. So that's what the things you're fighting against and trying to see the odontoid is the palate anteriorly. Yep. And what? This is the posterior ring of C1. So obviously this would not be confused with a fracture in this particular view because it's explained by the arch. It's very smooth and curvilinear. But and then again, knowing that this is the posterior ring of C1 and this is the palate, if you can't see what you're looking for, you can tell the tech to not get the patient quite so extended or not get quite so flexed.
Okay, so this is what artist's rendition of what the anatomy should be. And so how would you treat this, Mesfin? So the 69-year-old man on your service, I saw him 2 weeks later in the office, odontoid fracture,
Well, I think for.
many medical problems.
Right, for this population, I would just follow him with serial x-rays, and I would accept a stable pseudoarthrosis in a patient like this. Someone that is low demand, high morbidity, if they get a nice fibrous union there and it doesn't translate, then I'll accept it, even if it's not a hard building union. So I would lean towards treating him non-op. If I see it displacing, if I see translation, then I would go to step 2, but I don't want to do.
Like an Aspen collar or something?
Initially, hard collar, not a halo.
Okay, so I learned from whenever you say things, because you do a good job with things. So would you see him next week, every 2 weeks? How often?
I'd probably see him initially 2 weeks, and then if it's stable, then I can start spreading it out. It's going to take a long time to heal, so this is not going to be a 6-week collar treatment. He's probably going to need anywhere between 2 to 3 months in a hard collar.
2 weeks, 4 weeks, 8 weeks, 12 weeks? Is that how you do it? And how do you diagnose union? Would you get a CAT scan? Because it's hard to see on the X-ray.
No, because I'd be less concerned about a bone union and more concerned about translation. So
when you take the collar off, that's the question.
Take the collar off, probably at the 10-week mark and get flex X views.
So flex X views are negative at 10 weeks and patient has no pain, obviously. Then your diagnosis is stable non-union versus or union. Okay, yeah. All right. So and what are the other options? Frank, for this guy? What are all the options you could do for him? So non-operative hard collar is one.
Yeah, I mean, you could do a halo, but no one recommends that because, older guy, he's going to have a lot of complications like aspiration, pneumonia, possibly death from that.
Mm-hmm.
You could fix them.
When you say fix, what does that mean?
You could go posteriorly. You could do like a C1-2 fixation. You can even do occiput to C2 fixation. If you have the right fracture orientation, then you could do anterior screw.
Okay, so anterior screw versus posterior C1, C2 instrumentation. And look at the arrow. Why did this guy? What's maybe a reason why he fractured? Look at the arrow. What is it pointing to? The C1, C2 joint. Mm-hmm. Describe it.
Yeah, so it's
is that normal? With his C1, C2 articulation?
Yeah, I think it's a normal articulation. I think it's like a hyperextension injury where the anterior arch.
I'm trying to get to something here. How much space is there between the C1 and C2? Okay.
Yeah, it's normally about 3 millimeters.
There's usually some cartilage, right?
Yeah.
And does he have cartilage there?
No, it's fused.
And maybe not fused, but arthritic. And is this a small C1? Is it enlarged? Is there extra information?
I think it looks normal.
I think it's a bit hypertrophic. I think this is a very arthritic C1, C2 articulation. So why would that predispose him for a fracture? Would it not predispose him? Would it predispose him? What do you think?
If there's not the normal motion there, it could predispose him.
Increased stress to C2, right? And what about the rest of his spine? Does he have normal discs here?
Yeah, it's all multi-level disc disease and arthritis there.
Yeah, so those discs, are they stiff? Are they mobile? So why did he fracture, you think? Put this all together.
Yeah, it's kind of like a long lever arm.
Yeah, and very stiff cervical spine. And the odontoid, look at his odontoid right here. Is that normal bone? Is that
cystic?
A little bit osteoporotic, right?
Yeah.
So it's kind of like a stress riser in a very stiff neck. That's where he's going to fracture. Because he doesn't have motion. I don't know. I'm just making this up. Maybe I'm wrong.
It's kind of like a dish type situation where you have a stiff above and stiff below, and the forces are going to be through the point of least resistance, which in this patient is probably the odontoid. I think that would be a consideration towards whether you fix this or not. I mean, if you have, I know, Metzen, you mentioned about if there's translation. I mean, I don't know how you would really determine that in the acute phase unless you tried to do a flexion extension X-ray on him. I mean,
You know there's translation here.
well, exactly, so the point is you have translation, so you had said earlier that if there's translation, you would more likely fix this. I think that if it's someone like this, if you have the situation where you think biomechanically that area was predisposed to fracture because of the osteophytes and stuff, and there is translation, and it's a posterior displacement like this, this is one where I think if you could, you would want to consider fixing it. I mean, he certainly has it's predisposed to fixation because all you have to do is tip him forwards a little bit, and then you've got a pretty good shot from where the C2 is. Depends on if he's got a barrel chest, depends on his comorbidities, but I think that this would be maybe a little less likely to heal because of everything that we talked about, I think. If it was a younger guy, a little healthier guy, then certainly I think you'd want to stabilize this.
You guys follow what Dr. Adorn just mentioned in terms of decision-making having to do with whether or not you can place a screw here?
Where would you typically make a decision for? Are you going to go through this later on?
Yeah,
Okay.
I will. We keep going.
Okay.
So just, we have more things to talk about, a lot of things to talk about. So non-union risks, who fuses, who doesn't. Older people tend to have non-unions, displaced more than 50% or 5 millimeters. The dens is only 10 millimeters big. Angulation, say more 10 degrees, comminution, and delay in treatment if the collar never goes on. And why do they not heal? There's ligamentum forces of the head pulling it. It's not opposed, like this one's not going to heal, and distraction.
The one thing to add to that is posterior displacement. They have higher risk of non-union with posterior displacement because of the vascular issue.
This one's the best case.
Vascular supply comes in anteriorly. And so if it's posteriorly displaced, you're going to have more vascular disruption as opposed to if it's anteriorly displaced.
So this is an interesting case that I think explains a lot. This is actually a patient of mine, 91-year-old woman who had low back pain, and she said, my neck hurts. So I said, well, let me get an MRI of your neck, make sure you don't have tandem stenosis. And that's on the left. So very severe, wouldn't you say, cervical stenosis. And she had loss of bowel and bladder control. And you see the CAT scan. And I basically told her, you need to have cervical surgery first because this is life-threatening at this point, I would say. So then I did an occiput to C5 laminectomy fusion. So what do you think? Somebody comment on the dens, pre-op dens, this line across it, and post-op dens. What do you guys think? Does it look the same? Does it look different? What's going on?
It's reduced a little bit more anteriorly, but I think the line is definitely still present. I don't think that it's.
So there's this line here.
Yeah.
She has no history of trauma. And look at the dens. Look at the back of the dens post-op. Straight, right? And look at the pre-op. It's a significant angle. So I think this is, I don't know what it is, but most likely this is a chronic os odontoideum that she most likely has had all her life, and it presented with severe cervical stenosis at the age of 91.
Well, my question was, there's like a lot of ligament is thickening in there too. It seems like
Posteriorly?
Posteriorly and anteriorly, according to the cord. So like the.
So it's a little different. Like this, we call C2 panis, is what usually we call it, and this is posterior ligamentum flavum hypertrophy. Why would that be? Why would that be excessive ligamentous hypertrophy?
Well, it's trying to stabilize, and that makes me think it's chronic.
Yeah.
How would a fracture that went on to pseudoarthrosis look on MRI compared to what you got this sort of like almost like joint looking like os that you described?
It depends.
How does that compare to pseudo?
Similar, but this is smooth.
Gotcha.
This is not.
Smooth that is.
Yeah.
It doesn't look like a fracture. It's just, especially if you look at the MRI on the far left, it looks like you would look sharp using one smooth stroke.
So this, you could see this happening in a cervical non-union, but in this case, it took 80 years. So it may take a long time. I thought this is a very interesting illustrative case. The also interesting thing is the neurological tissues did not resume a normal shape, and that gives you an idea of how old it is.
Yes.
Yeah. She's about a year out. I could repeat it. So So this is odontoidium, which is sort of a similar problem. So I'm just going to go quickly over these things. The odontoid separates from the atlas, from the C1, at the 6th week of gestation and moves caudally and fuses to the C2 body. And it's 10 by 10 millimeters, 15 millimeters long. And I won't go over this anatomy, but suffice to say that all the residents should memorize all this anatomy and all the ligamentous anatomy. And the ligamentous anatomy at C1, C2 is always a test question. And what's the most important, what's the strongest, most important ligament in the cervical spine? Yeah, transverse ligament, right? And what does it do?
So it basically keeps basically it maintains the radiolaxial kind of junction and allows for rotation of the cervical spine, but not flexion.
Yeah.
Excessive flexion.
Yeah. Yeah, pretty good. So I won't get into this because this is you read it on your own. But you have to memorize that. So we talked the halo fixation, C1 fixation, what kind of neck do you need to do the C2 screw, Frank?
Like a long, thin neck.
Mm-hmm. Yeah. Without
the barrel chest.
Without a barrel chest. Yeah. Like,
why is that?
It could throw off your trajectory for the screw. You can't get the.
Use your finger like a gun and shoot into your C2. How would it look? Yeah. Yeah. So you can see if he has.
Some of the younger guys, it's sort of like pinning a hip. You know, you've got to put in a hip screw. And you've got somebody who's really overweight, and you're struggling against the soft tissue on your lateral thigh. And you've got somebody with a lifted trim or something pushing that tissue in while you're trying to get the angle. It's the same idea here. So you want to figure that out before you make incision. Whereas if you make incision and put your, whether you're going to use a power device or what have you, the bottom anterior cortex of the C2 body, this is what you see there, and you try to drop your hand to get the angle, and you can't, then you've got to stop, close it out, flip the patient, and do a posterior orthodesis.
It's like pinning a skiffy. You remember how you pin a skiffy? Same thing. You put the wire front. Yeah, you put the wire pre-op, two views, the wire two views like a skiffy. Don't you guys do skiffies like that?
Not yet. We will.
But you learn where the incision is. Like it's usually not where you think it would be because and you do it with two wires, AP and lateral. And this is what the other thing is. What Frank mentioned was the Harms technique, C1, C2 that he published in 2001, just inferior to the posterior arch of the atlas. And the C1 goes slightly medial and 22 degrees cephalad. But my rule of thumb is, I don't know everything, but I look at every CAT scan. And I think every C1 and C2 is slightly different, and you just got to plan each person. Because I think it's very, and guys, you tell me how you do this, how you think about these things. But this, especially this thing, this foramen transversarium C2 is extremely variable. They can be anywhere in C2. So that basically tells me what to do. Also the alignment of C1. So every case is a little different. Okay. And so we talked about medial, usually people say 10 degrees, this is 17 degrees, cephalad 22 degrees. But again, you look at the pre-op C2, the pre-op CT, and the screws 3.5 millimeters, usually 26 to 32. And the posterior arch of C1, it can be thin or it can be thick. This is from Charlie Seals and Dan Gelb's article in 2009. But basically, if it's too thick, you have to realize it's too thick because then you can't get a starting hole. You can just remove that. You can just take it because the vertebral artery is up here. Obviously, it's very close, but if you know where not to go, you won't hit it. And you just thin this down and just remove like that much to put it in C1. So and then you pull the nerve downwards, which it shows you there on this image right here. And do you think you can cut the nerve? Dan Rue, do you believe in that, Messin? You can cut the nerve?
I don't, but a lot of people do.
It was studied by Dan Rue.
Yeah, you can cut the C2 nerve and tell the patient ahead of time that the back of the head's going to be gone. It'll give you, if you do it in the lab, you'll see how much better your visualization is of the C1-2 joint. With that nerve out of the way, you'll see the joint really, really great. And then you can decorticate it, put a burr in there, pack it with bone, etc. I like to preserve it, so I'll pull it down for C2, down for C1 and up for C2.
So this is from Dan Gelb's lecture, as you can see on YouTube. I suggest everybody who's interested in this listen to it. But his technique is he puts the burr in just for the starting hole, and he doesn't look at it, and he doesn't try to see it. It's all basically percutaneous under fluoro. Okay, so now Grant's going to discuss this article, which I feel everybody talks about. It's going to be a test question, very relevant.
This article is entitled AO Spine North America Geriatric Odontoid Fractional Mortality Study. This is by Chapman et al. Published in Spine 2013. Retrospective multi-center cohort study. Basic objective of this study was to assess the differences in short-term and long-term mortality, operative and non-operative treatment in elderly patients with type 2 odontoid fractures. So some of the background, Dr. Antonides has already gone over very well, so I'm not going to belabor those points. Basically, though, there is controversy regarding whether operative or non-operative management is the best treatment for elderly patients with type 2 odontoid fractures. Obviously, the risk in the elderly patients of a non-union treated in when you treat them non-operative higher than it is an operative treatment, but like Dr. Lemma said earlier, the more recent studies have shown that it's possible that these non-unions really don't matter in terms of neurologic outcome. That fibrous non-union does just as well as a union. So they had 3 large level 1 trauma centers which are used to identify consecutive patients that were 65 years or older with type 2 odontoid fractures between the years 2003 and 2009. They identified 322 patients. They looked at data including age, sex, living arrangements prior to injury, which we know in our fracture patients is always very important, whether they're independent versus assisted living facility, versus a nursing home type situation. Mechanism of injury, comorbidities, initial treatment modality, so operative versus non-operative. They did not distinguish in this paper between like C1-2 fusion versus an anterior screw. Length of hospital stay and ICU stay, and whether a feeding tube was placed, as well as whether discharged. So average follow-up they had was 647 days, so about 2 years in the non-operative group, and around 851 days in the operative group, so a little bit longer. Mean patient age was 81 years. Operative treatments were younger than non-operative treatments, so operatively the average was 80 years old, non-operative 83 years old. However, the operative and non-operative groups did not differ significantly in proportion to males versus females. So in terms of their outcomes they found, the vast majority of patients, like Dr. Antonides said, sustained their odontoid fracture from a ground level fall. In terms of how they did compare with the non-operative treatment group, the operative treatment group did have a significantly longer mean stay of their initial hospital stay and had a longer stay in the ICU. Operative patients were more significantly or more likely to be treated with a feeding tube compared to those that were treated non-op. However, the dispositions for these patients in terms of home or to a SNF or if they died did not change. The one thing that this big paper did see was that they looked at short-term 30-day mortality within 30 days of presentation. 46 of the 322 total patients overall had died. So this obviously, we were talking about this earlier, it can be kind of a sentinel event.
So 14% died within 30 days.
So it's pretty significant mortality after this injury. The rates of mortality for males and females did not differ. However, the hazard ratio for death within 30 days, when you look at the non-operative treated patients versus the operatively treated patients, was 3.0, reflecting significantly poor survival among those that were treated in the non-operative fashion. When they went out to long-term mortality analysis.
So let's just break it down. So 22% death if you don't have surgery in 30 days versus 7%. That's a lot of deaths. Okay.
In terms of long-term, they did have 661 total patient years of follow-up. Of these, 276 patient years were non-operative, 384 were operative. The mortality rate from males at the long-term analysis was significantly higher than females. And after adjusting the effects of patient age, sex, comorbidities, Patients treated operatively had a non-significant trend towards lower risk mortality at the time of last assessment compared with those treated non-operatively. When they went out the long term,
Which is average 2 years.
average 2 years, that mortality benefits was maintained for the operatively treated group, which
Yeah.
is another good takeaway.
So all comers, 44% death at 2 years.
That's remarkable.
I mean, that's amazing. What's the hip fracture death at what's the hip fracture death percentage?
Yeah, all comers at 1 year, it's like 30%.
Is it 1/3, 1/3?
Yeah.
So 1/3 at 1 year are dead, 1/3 at 1 year are not dead, but decreased ambulatory capacity, and 1/3 at 1 year have the same ambulatory capacity.
So 1/3 are normal, 1/3 impaired, 1/3 dead at a year.
It's easier to rationalize that because you say, here is this geriatric patient that is now rendered non-ambulatory, right? So, or partial weight bearing, or what have you. So, bedridden, many of them. But this is just a little tiny bone in your neck. And it's a little bone, and you can still get up and walk. So why do so many people die?
Yeah.
Okay, so there's a lot of deaths, and the operatives less likely to die. It's pretty significant. This is going to be a test question, I'm sure, for you guys. So everyone knows the Anderson-Alonso classifications, and then there's the Grau classifications, which goes from anterior, inferior, posterior, superior. Just there's a difference to it versus a transverse.
So which one of these would not be amenable to a screw? ABC, DE.
Well, the screw goes from anterior up here. So which one of these two guys? Yeah, see, it'd be really hard to catch
Right?
this.
You can't do it, so that's another thing that comes up. So your screw's got to go relatively perpendicular to the fracture line.
So see, the screw would
So
be.
type F would not. So you got to look at that line. If you see one oblique that way, then you can't put a screw in front.
So your screw's got to be, just like every fracture, it's got to be 90 degrees. The fixation has to be 90 degrees, so that's how the other one wouldn't work.
When you guys pin a hip, you use one screw, 2, 3, 4, 3. So what about here?
I guess you just use one.
So do you use something to hold your rotation while you're putting the screw in there?
That's the point, right? So because if you put one in or one in a pin or 2 screws, and what's the literature say about that? What's the downside for putting in just one?
Well, you don't control your rotation.
You don't control rotation as well. What's the downside for putting in 2?
You don't have much fun.
Real estate.
Yeah.
You know, I mean, it's just like it's the size of a postage stamp.
All right, how big is it? We just went over, how big is it? 10 by 10, right?
Yeah.
How big's the screw? 3.5.
Yeah, it's very that.
So we're talking like just a couple of millimeters.
So what do you do? 1 or 2? You just do 1. Okay, so data has shown that 1 works fine. Some people still do 2 to control rotation.
Yeah.
Do you find that,
Yeah.
you find that, it's harder to control rotation with like type ABC fractures compared to the ones just because it's rotating?
Yeah, sometimes. So sometimes what you have to do is put in a guide wire off center, hold it while you complete the procedure, and then take the guide wire out just to keep it from spinning.
Okay, so just a couple more articles. So that AO spine study was 2013, and that generated a lot of articles after that because basically the article is a proponent for early surgery in these elderly people, and it's not a simple case. I mean, it's a big case for these old people. See, once you do posterior fusion, which risks. So this article was from 2017. 19 retrospective non-operative treatments. 40% had no symptoms, and 25 these are non-operative treatments. 25% of these people fused, 40% asymptomatic at a year, and 68% were satisfied. No one was very dissatisfied. This is non-operative treatment. This is another review study from 2010. But basically, the issue is there's a high non-union rate. They state 30%, but other studies mostly more like 20%. And non-union rate increases with age. We discussed that. And then as you get older, there's a higher likelihood you're not going to see the next year. So basically, 75 to 79 years old, these people on average, this is from actuarial studies, they live between almost 10 years or so, life expectancy for all comers. If you make it to 75, there's a high likelihood you'll live a lot longer. This is a review article from Todd Albert, and he basically, for the people who like these sort of things, you don't have to think. He states type 2 fractures, if they're displaced, should have surgery. But having said that, you have to go over the risks of surgery, which are pretty significant. So most old people don't want to have surgery because they say, I'm too old for this, too many risks. And this is one last article from 2015, British Journal of Neurosurgery, a conservative management for type 2 and type 3s. They found no difference between the halo and the hard collar, and that a stable fibrous non-union was perfectly acceptable, but you have to closely follow it and see if it displaces. And this is just people who either they're stable, basically fibrous non-union or union collar versus halo. So this is, so we'll get into, thanks for coming, Paul. What are these lines here in this child? Yeah, the physeal lines, right? And this hasn't even ossified yet. So the secondary ossification center appears at age 3 to 6 and fuses age 12. And this one fuses at age 6, but can remain X-ray for a long time. And a third of people have a line here, like a physeal. What do you guys call that? We used to call it physeal scar. Yeah. So a third of people have that physeal scar. So this is like a severe case of ossa odontoideum with spinal cord compression in a child. So this is an interesting case I saw in the office the other day. A 55-year-old woman with central axial neck pain, no radiculopathy, no myelopathy, and here are AP and lateral views. So what do you think of the lateral view, specifically C1, C2 junction? Somebody?
Yeah.
Yeah.
Yeah, I do actually. A lot of people have hearing. So what do you guys think? C1, C2 articulation. Should C1, see the anterior arch of C1? Should the anterior arch of C1 be posterior to this line? That's weird, right? That doesn't look normal. And the patient also has degenerative disc disease, so I thought this was very suspicious. The oblique views are kind of were non-contributory. But what do you think of the flexion extension views? Somebody, what do you think?
I think there's some posterior subluxation of that, as that juncture with the extension views, and then I think anteriorly, I mean, it doesn't reduce, I think that it's.
See the front? Yeah, that's the front of C2, right?
Yeah.
And that's the front of the dens.
Yeah.
So what does this patient have? No trauma. And it lines up here, anterior dens, anterior C2.
Instability of some sort.
Okay, so what do you think of the CAT scan now?
It looks like an old fracture off that has nice curved doors edges. There, yeah.
Yeah, so here's the fracture line. Yeah, it's a fibrous non-union either of a fracture or ossa odontoideum, which is developing arthritis, which is very similar to our 90-year-old lady, remember?
Yeah.
And she has no history of trauma. You would think a normal person, she's a normal person, like a normal, yeah?
When this happens, when this rolls into your office, someone who has been treated non-operatively and now all of a sudden they become unstable, would you just use them, C1, C posteriorly, just use them?
Yeah, if you did have it, yeah.
Okay.
But this person just has neck pain. So what would you do with her? You have a CAT scan, would you get an MRI, Frank?
Yeah, you want to see if there's any compression.
Yeah, and you see C1, C2 is there's a cystic change of the dens from arthrosis. And then here's your MRI. What do you think of the MRI, guys?
It redemonstrates your non-union or your non-united os. There's maybe a little bit more ligamental hypertrophy. You've got plenty of space. There's plenty of space available for the cord.
Yeah.
I don't see any cord signal change. But you can see where the cord's kind of deflected a little bit.
Yeah. So plenty of room, space available for the cord. What are the other issue is, what do you think of the pannus? C2 pannus, where people usually develop pannus. Does she have one?
a very mild.
She doesn't have one. Yeah. Unlike our 90-year-old woman did have some.
Mhm.
So what would you do with her?
I mean, you could talk to her about, if she's got neck pain, is the thought that a lot of her neck pain is from this pathologic motion of C1, C2?
What else could give this patient neck pain?
Yeah, they are.
Yeah, and she has how many?
Yeah, lower cervical spine.
Yeah, so this one's degenerated, this one's degenerated, this one has spondylolisthesis, so all of this can give you neck pain.
Is it ridiculous?
No, just axial central neck pain. In a normal, very attractive woman, 50-some years old, healthy, you know, she's, huh? She's not, my point is she's not sickly. She's like very healthy. But these, I mean, no, but these are important human factors. Yeah, this is like a robust, healthy woman. You know, and what do you tell her? Like, what would you do with her, Frank? Both occipital, posterior, axial, central neck pain. So occipital and center.
I wouldn't operate on her. I mean.
Okay, so you're not going to operate on her. What are you going to tell her?
That she either lives with it, you can try injections, other conservative measures. But
yeah, so you treat her non-operatively with nonsteroidals and follow her closely, right?
Yeah.
Say, hey, you've got this unusual problem. This is what I think we should do. Unusual problem, probably from childhood. This thing should have fused at age what? 12, right?
Yeah.
So if age it fused 12, and it never fused, and now it's developing arthritis. Very interestingly. But there's no pressure on the spinal cord, but it's a really serious place in your body.
Yeah.
So it should be watched.
So I have a question.
Yeah.
So you counsel this person on all of these things, and then you say, and say this person, goes and gets into a car accident or something like that. So
Yeah.
something that someone else may kind of walk away from.
Yeah.
But then she's got like significant glenoaxial.
Yeah, Dan Rue studied that actually. People with severe cervical stenosis, are the risks of a car accident greater than surgery? The risks of surgery are greater than the risks of the accident. So it's really not something you should tell people.
So it's not like a myelopathy sort of situation, because I know we counsel people, we want to operate as soon as possible to, prevent progression, but then also if something bad happens to you, you fall somewhere and you could have catastrophic.
Very, very low probability, although I see it. So when you're a shock trauma, you do see central cord syndrome comes in elderly people with car accidents. But usually not. The denominator is really high. There's a lot of cervical stenosis out there walking around.
Yeah.
Most people do fine.
Okay.
So I don't think that's a reason to do surgery. Now, in this case, but let's say the patient had severe, like our 91-year-old lady, severe cervical stenosis, spinal cord signal change, deformity of the spinal cord. That's a different scenario. Okay. So, I mean, basically, I told her, just get another MRI in a year or two and just watch it. And the axial was normal. And these two, just if you guys, before you go out on a Friday night and you're drinking beers, you should watch these two lectures. This is Chapman's review lecture from Seattle Science Foundation, and Dan Gelb's lecture from 2020 on occiput C1, C2 fusions. These are great YouTube lectures. That's it. You guys ever been to Dundee Creek? That's a picture of me. Yeah, isn't that incredible?
Is that in a canoe?
Yeah, that's my son and my nephew on Dundee Creek in Middle River.
That's in Middle River?
Yeah, Dundee Creek. It was beautiful. I had no idea Baltimore would be so beautiful. It's amazing, right?
See YouTube. It was nice.
Yeah, it's a huge thing. All right, so any questions about occiput? C1, C2, dense fractures?
Is there any, a lot of times they call us, they don't have x-rays. It's always a CT scan. That's what the ED and the primary genomics scans.
Yeah.
Say that thing is the odontoid is very posteriorly depressed. You can tell in the CT scan that it has to be abutting the cord in some manner. Even though you don't have an MRI. Is there any scenario where you don't get flex X views?
Okay, so let's just say, let me change the question a little bit, and let's say the question is, when do you not get flex X views, or how do you handle flex X views? So flex X views is you can almost always do them as long as they're observed.
Yeah.
So when the patient gets symptoms, you don't push past the symptoms. So in cervical, like there's another scenario. I'm a spine surgeon, so I frequently do cervical cases. And in the office, I tell them, go back as far as you can. And people with severe cervical stenosis, a lot of them can easily do it. So those patients can do flexion extension views. But some people go, I can't. And some patients say, I can't look up at all. Like when I go up like this, my hands go numb. Those patients do not get flexion extension views. So usually if you talk to a patient, they will tell you what they can and cannot do. So it's usually simple. Did I ever tell you the story of the Iraqi girl who wouldn't put her hand off her face? Yeah. So patients know when they have a problem, just so you know that. So when I was a fellow like you, an Iraqi girl came, this was 98 during the Iraq War, and she had been dosed with a lot of chemical agents when she was like 2 or something, and she was like 8 at the time. And the chief complaint was the parents said she came from Iraq, she would never take her hand off her face. That was the chief complaint. Like, what? So the attendant goes, get this girl to get her hand off her face so we can take an x-ray. And that was my goal as a fellow. You know, I'm like the fellow, I can do everything. It's like, I was like, John, she will not take her hand off her face. I mean, she would not. And do you know why she would not take her hand off her face? Just get anybody guess. Yeah, she had a chronic fracture of C2 that no one ever knew about. That she was stabilizing her neck and her head, and it had fractured and it had elongated. So it was a horrible case. So we finally got her in the CAT scanner and we saw it, and it was like, oh my God. So she developed this. I guess it was, I don't know how she did it. Huh? It was a fracture through the pedicles and had elongated. So it's a really weird developmental anomaly that she had. But patients know when something is wrong. So that's why you can just ask them. They'll know, I easily do this, I can't. All right.
She was out unstable though when she got the CAT scan. Did she have a collar on or anything? Or?
Yeah, we put a collar on her, and then we did this C1, C2 fusion. It was a very interesting case. All right, any other questions or comments? All right, guys. Yeah, thanks for participating. See you next month. I'm gonna go up and see.